particularly as the external financing landscape shifts. Now to Professor Daman. Professor Daman, in the context of declining external financing, how can Ethiopia strengthen self-reliance to safeguard essential SRH services, particularly maternal, newborn, and adolescent health, while maintaining equity and quality under HSTP2 and HSDIP?
Okay, thank you very much, Dr. Abdul Hamid. I also want to thank the Esog leadership, for giving me this privilege to talk on the issue of self-reliance in SRH services. As all of you know, the sexual and reproductive health is a critical issue within the health sector, as well as in attaining health status in the country. One, it is a key pillar within the essential health service package of the country, as well as the major health sector program, which is HSTP. In addition, it's also linked to women's education, which is, consistently showing correlation with health status in the country. Econometrics analysis has, in several estimations, shown that female education is one of the critical elements in the health status of our country. And last, SRH services are vulnerable to shocks within the context of declining development assistance, because historically, as the services were reliant, like 50 to 60% of the services were being financed by development assistance. So there is a need to get focused on what to do regarding the financing of these services. The most important issue is, to protect the critical services, which we call the minimal initial service package, which include skilled birth, ensuring the skilled birth attendance, ensuring the provision of emergency obstetric care as well as neonatal care, providing family planning within a sustainable manner, responding to gender-based violence, and also responding to or continuing sustainably the HIV and STI response, as well as securing commodities for essential SRH supplies. So this would require a set of activities within the sector, as well as within the overall government, to ensure the sustainability of these services. One most important element is, of course, increasing government budget. Budget that comes through tax. As all of you know, several areas within the country has shown increase in tax, but we are not very sure if this also corresponds with increased budget to the health sector. So this is a critical issue. We have to advocate, especially professional associations like Esog needs to advocate for increased allocation of government budget to the health sector, as well as mainly to SRH services. As you know, the government is doing a lot or increasing tax and doing a lot using that. The other most important element is integrating SRH services within the currently, growth to push for the rapid implementation of resources for the health sector, as well as for the critical services that we want to protect, such as sexual and reproductive health. And other most important areas that we should focus is strengthening public-private partnership in the area of sexual reproductive health, as well as overall health sector. We can do a lot in generating resources through public-private partnership, as you may have seen in the case of the corridor development in Addis Ababa, as well as in other major towns of the country. This, and even though the development assistance is declining, we have to focus on these services, on the protected services, to channel whatever we are getting to these services that we care about. Thank you.
Thank you, Professor Daman, for your insight. If I ask some questions, if you could expand on what practical examples of domestic resource mobilization or efficiency gains show promise in Ethiopia or comparable settings.
Services that would show efficiency gains would be, I have mentioned some of them. I have mentioned some of them, but the others would be services with higher potential for efficiency gains would be strengthening the supply chain efficiency. I don't think we are efficient in our supply chain management, especially for essential SRH commodities. And we also have to be efficient in cost saving by integrating services. For instance, we have to integrate some of the services through task shifting within the health extension worker program, and we have also to reutilize the previously applied strategies such as outreach services for some of the activities, and that would decrease cost and create some efficiency. And using also technology, the emerging technologies like digital health would also create efficiency in and bring about potential gains in the delivery of these services. And we have also to try to decrease inefficiency within the current health sector, as well as within all of overall government, so that we cut bureaucracy and also allow, for instance, waradas, or what in English districts, to generate their own focused resources for the services that we care about. Thank you again.
Thank you, Professor Daman. Professor Daman highlighted that SRH services is vulnerability to shock, and 50 to 60% funding comes from developing partners, and protecting minimal service package like emergency obstetric care GBV, HIV is very important. And there is a need because in the fund cuts, there is a need to have increased government budget. Also, some approaches are social insurance system, which is lagging in Ethiopia case, and there is a need to strengthen in that approach, and strengthen also public-private partnership. Efficiency gains have been also highlighted, strengthening supply chain efficiency, cost saving, and integration with programs like health extension workers program and the use of technology. Thank you, Professor Daman, again. And now, because our presenter, our panelists did not join us, I will go to the human resource panelist, Dr. Daniel Dereje. Daniel Dejene, sorry. So actually, the pillars are connected, the financing, the supply chain, and we will discuss the supply chain after completing the presentation from panelists here. We'll touch that part as well. So, Dr. Daniel, how can Ethiopia build a resilient SRH workforce in number, skills, mix, geographic distribution, while addressing motivation, compensation, safety, and job satisfaction, particularly in underserved and crisis-affected areas?
Thank you, Dr. Abdelhamid, for inviting, and I also thank Esog and Esog leadership, Dr. Haile for inviting and to be here before you and discussing this issue. Before I talk about how Ethiopia build a resilient workforce, let me highlight the critical workforce challenge in Ethiopia. I think this challenge also applies to the other countries in Africa because we have similar context. So the first one, Ethiopia is one of the countries with severe workforce crisis, as WHO designated our country. So the most important, the critical challenges is one of the challenges, the shortage. Yes, Ethiopia invested a lot to expand its health workforce, its pre-service education, not only the undergraduate but also the specialty workforce, but still there is a shortage. So between 2005 and 2025, we expanded pre-service education. We expanded the workforce. In 2005, we have like 68,000 total workforce. Now, like a year ago, we have around 380,000. That's actually 6 times in terms of stock, in terms of number. But that is not enough because the population of Ethiopia is growing at geometry progression. So if you do the math, the density is only 1.5 doctors, nurses, midwives, officers per 1,000 population. So this is very low as compared to the SDG threshold 4.5 or the sub-Saharan African average 2.3. So this is the first challenge is shortage. The other is competency gaps because of the quality of education, the access of continuing medical education, continuing professional development, and the regulatory mechanism also at infancy stage, not developed. The licensing examination, the accreditation system. So the quality of education and quality of health workforce is not dependable. We have done studies in which I have been a part of research studies. Those studies indicate that our health workers lack critical the hands-on skills, psychomotor skills, obstetric skills, surgical skills, medical procedure skills, and our health workers also devoid of skills related to communication, ethics. So these are the major skills because of the quality of education, because of the access to CPD. The other important gap is about the motivation of our health workers. Our health workers, again, from the studies, like 1/3 of Ethiopian health workers, this is actually referring to the national study, it's claimed that like 1/3 of health workers lacked, they don't have the the job satisfaction. So if you see cadre by cadre, the physicians, health extension workers, they have like 50%, or more than 50% of those health cadres do not have, they are not satisfied with their job. Why? It's because of, especially because of, the compensation, the salary, the base salary and the allowances, risk allowance, DTO allowance, housing allowance, everything is not, adequate to the need. I'm not actually denying what the government is doing currently, especially currently, the government changed the salary rate, improved the salary rate, and improved the allowances, duty allowances. It's also provided, medical insurance for health workers. That's commendable job. But if you see, the market rate, it's not enough. The other related to other factors related to motivation, the workload, workplace management, supervisory support, career paths, all these are actually contributing factors to the low motivation of our health workers. Again, if you see, the skill mix balance and the geographic, distribution, again, it favors to the urban areas. It's left behind, the rural areas, remote areas, and those people living in less developed region. So these are the most important, gaps, critical HRH issues in the country. So what are the solutions? I think in order to improve, the shortage, I think we need to strengthen the pre-service education so that they enroll more students, support them to produce more health workers. This is from the supply side. But from the demand side, from the health sector side, again, the health sector should be supported, to hire, to employ those who are produced from the pre-service education. Back in, I think in 2022 or 2021, there is a health labor market analysis study conducted in this country. So of the total 25,000 annual graduates, it's only like 90% of general practitioners were not employed after 1 year. 34% of midwives were not employed again after 1 year. So the health sector should be able to, prepare itself to recruit and to deploy those who are graduated. And again, from the demand side, I think the health sector also should be able to address, retention. Again, the total attrition rate of health workers in Ethiopia is like 4% or 4.5%. If you take, the involuntary attrition, every year Ethiopia loses like 10,000 health workers. We train, we graduate like 24,000 every year, but we lose like 9,000, 10,000 health workers because of involuntary attritions, voluntary attritions, I mean. Because of the motivational issue, because of, unsuitable work climate, because of poor supportive supervision and career path issues. The other, in order to address, the quality, competency of the workers, actually we should invest on a quality of education. We focused on, quantity. That's called, the quality of pre-service education, and then like those licensing examination and review what factors actually affect the motivation of our work, non-monetary issues like, so that should be the starting point. But generally, I think compensation should be revised. Compensation should be, improved. It should be adequate to the market, the living cost of the health workers. Yes, we cannot deny the Ethiopia government is doing a lot in this regard, but it should be proactive. It shouldn't respond to this regard, but it should be proactive. It shouldn't respond to the resentment of our health workers. And again, we need to work on other non-monetary incentives like performance-based incentives. This is really, really important. Improving the workplace workplace management, and addressing, the career paths and access, increasing access to CPD. To address, the maldistribution and skill making balance, I think one of the issue is, the capacity, the infrastructure, the health infrastructure down at the regional health bureau, at the regions, at the health facilities. So that is really important in order to retain their health professionals. So we need to ensure access to, having adequate medical equipment, level, at health facility level. That's actually, we need to address, the push factors. So this is what I want to reflect on. Thank you.
Thank you. The solutions to address these problems. If I will, I'll expand on this. And given Esog's assessment,
okay, important strategy. It's recommended by WHO, especially for countries like Ethiopia, to essential health services, increase, coverage, service coverage. This is important because we cannot, avail senior specialists or physicians everywhere. So the task sharing is important. So let's agree on that. And then task sharing is about, redistributing tasks to the mid-level professionals. Of course, it needs proper training. Proper training should be there. And then once mid-level clear guidance in a place within Addis Ababa, it should be, because in a specialist, if you properly, attainment of universal health coverage for the countries, so that's important. But one thing I think I see is because of the scope of practice, be in that have to be properly managed. It should be integrated, emergency surgical obstetrics, officers. They are assigned. They are given tasks of obstetricians and surgeons. They served a lot. We should acknowledge that, but we should set a strategy because they need a career path. Once after to do this, I think task sharing is important strategy to increase access. If we properly manage it, I think it increases teamwork. It's also quality of care. Thank you.
Thank you, Dr. Daniel. If I summarize what he has said before switching to the next panelist, he mentioned that Ethiopia is a country with severe workforce crisis, and there is also competency gap, motive and workload, and entry in high number. Education is also another issue. But I think the government is trying its best to retain staff, like non-monetary incentives already initiated recently. We also, with regards to the task shifting, he highlighted that there is a need to have a clear guidance. He has explained by integrated emergency of years ago. And he mentioned that if the guidance is clear, if there is a clear pathway, this task sharing help a lot in achieving the universal health coverage. Thank you, Dr. Daniel. Now, you know that resilient system must also learn and evolve, ensuring that evidence-informed practice and policy. So I will now go to Dr. Abel Gadafao. Dr. Abel, how can Ethiopia strengthen this?
For this presentation, what in Ethiopia actual scenario, rather than like in Ethiopia actual scenario, rather than like going through the vast literatures and so on and so on. So in maternal and sexual reproductive health, evidence-based maternal and sexual reproductive health, evidence-based every intervention. Whether we talk about the human resource, we talk about the supply chain, we talk about the task shifting, the key is evidence-based practice, what matters in preventing in addressing the problems. So in Ethiopia, evidence utilization is formally mandated by one institutions at the Minister of Health. So other than Minister of Health, there is no other institutions who have the mandate at the Minister of Health. So other than Minister of Health, there is no other institutions who have the mandate to change, to approve the guidelines. So to change, to approve the guidelines. So the ultimate evidence to policy, utilization mandate lies on the strategy revised every 5 years. Some guidelines changes depends on the availability of evidence. Some every 2 years, every year, sometimes every 7 years, depending on the new evidence. So the system looks like new evidence. So the system looks like strategies. So at the Minister of Health will establish a kind of committee, I can say, which involves many stakeholders from the society, academia, partners, and so on and so. So there will be a committee. That will go in detail strategies, the interventions. Then they undergo also stakeholder consultation, broader stakeholder consultations, and then finally the guidelines or strategy will be approved by the Minister of Health. So this is the process. There are many interventions, many evidence-based interventions that changes, that saves the lives of girls, women's mothers in Ethiopian setting. We can say, for example, women's mothers in Ethiopian setting. We can say, for example, the safe abortion care guideline, which was revised in 2008. That is the most important interventions which prevents maternal days in Ethiopia of maternal days. But now it's less than 10%, probably 5 to 7%, because of the implementation of evidence-based interventions. Actually, the evidence originated from the ground, from the local context of showing that high maternal mortality, the legal background, and so on. There is a very good opportunity in Ethiopian setting, probably which I hope will program evidence to policies already embedded in the health sector transformation program. Recently, and the most important one is, there is now a dedicated health policy and strategic executive director under the Minister of Health, which was not there previously. So now there is an establishment of institutions, that is the health policy and the strategic executive directors, who continuously undergo evidence to policy implementation. And again, now the universities are now assigning different roles. Previously, there are the many universities were doing many activities together, some educations, research, and so on. Now at the Minister of Health, the universities are assigned to track to research. The top 8 universities are now tracking or focusing on research. That means the research that is produced by this university is going to be most likely to implement to the program, the interventions, and the strategies. And recently, there is also an increasing use of routine data systems like the DHIS, HMIS, the surveillance systems. So there is now very good habit of using the routine data system for the program. So despite these challenges, despite this progress, there are key challenges. One, despite the recent initiative at the Minister of Health at Health Policy and Strategy Directorate, there is no institution at the national level or at the regional level, at the local level, who prioritize the research gaps. There is no institution at all. So ideally, there has to be some institutions who prioritize the research gaps. What is unknown in Ethiopian setting that helps to implement the program to address the research, the identified problems. So this is a very key challenge, which I hope in the next few years the Minister of Health will implement. There is an initiative at the ministerial level, but so because of this lack of prioritizing donor-based institutions, which is resource consuming. So because of this locally identified research priority, the evidence which generated from the ongoing research are weak in addressing the contextualized research gaps. The second problem is the limitation of funding. So even though we plan to have the institutions who identify the research problems, there has to be funding to address this research problem. So the other challenge is the limitation of funding. If we Google the maternal child health research publications in Ethiopia, I can say 95% of them are cross-sectional studies because of this limiting funds. At the most, probably retrospective cohort studies. Good quality research that can help for decision makers like clinical trials, implementation research, real-world effectiveness studies. They are resource intensive and they are, I can say, in the infantile stage. So the second challenge is the limitation fund, which the society, the Minister of Availability of the research funds, the saving interventions. Many of the researches, the evidences developed in the Western middle income countries that are not contextualized based or locally driven. So whenever there is evidence in the Western or in some other countries, when we adopt to the local setup, it requires many years to implement, to adopt. And the fourth problem is there is a very good habit in Ethiopian setup, developing, updating guidelines, strategies, implementations. But the most problem is translating these guidelines into practice. That is the major gap. The Minister of Health will develop guideline, will approve, implement these guidelines. There is a very weak system of monitoring, evaluating the success of these guidelines. So the basic gap is in translating the evidence into practice. And finally, the other problem is there is also a fragmentation of data, research, and decision making. In my university, whatever in the Ethiopian university, there are many research outputs, but most of these outputs end up with publications probably for academic promotion. So there has to be some ways these publications end up with the policy levels. So what should be the way forward? Probably one, institutionalizing. There has to be some institutions which translate evidence to policy, that identify research problems, that funds these identified problems with competitively, and also monitor the quality of this research and use the output for policy decisions. And the second way forward is strengthening the routine data systems. One of the major gaps in the Ethiopian system is there is routine data systems, but there are problems in the quality, there are problems in the comprehensiveness. So these routine data systems should be strengthened to use for priority setting and also for rapid learning outcomes and also to assess the success of the implementations. And the third way forward is there has to be a shift in research from the identifying the problem to assessing the effectiveness. Most of the output in Ethiopian system, I can say what is the problem, but we are not doing what is the best approach to solve the problem. What is the effectiveness of the problems? I think that's enough. Probably I will come again for the other topics. Thank you.
Thank you, Dr. Abail, for your excellent presentation. And just to expand on that, I have two questions. What prevents routine data and research findings from consistently influencing decision making? And how can professional societies such as Esog and Afog strengthen evidence to practice pathway?
What are the major problems in consistently using the data generated from an Ethiopian setting or in many African setting to the policy input. One, the quality of the data, the problem. What is the magnitude of hepatitis we should address? More real-world effectiveness study. For this, we need to have the funding. That's one of the problem. The second problem, even though we used the low cost effective routine data or routine surveillance systems like the DHS, HMS, again, there is a problem in the quality. I know there is a lot of improvement in Ethiopian electronic systems, but at these levels, there is an issue in the quality. Sometimes the HMS data says like institutional delivery is like 60–70%. But when you conduct cross-sectional study, you found like 31%, 40%. So there is a discrepancy which shows the quality of the routine system. So the routine system needs to be strengthened. Again, the electronic systems are fragmented. Like for example, one of the hospitals has an independent electronic data management systems. The other hospital has different data management systems. So there is no integration among the healthcare facilities. So that can be useful for the programs. Coming to what should be the role of the society like Esog in evidence to policy practice based on the best practice in many low-income countries, I mean, the middle-income countries, Western countries. One, Esog can be an independent SRH research priority institutions. So Esog can take the lead to identify what are the research priorities among the maternal health, sexual and reproductive health in Ethiopia. That can be provided for the Minister of Health, the funders, the partners. So this should be one of the role that can be updated actually annually or every 2 years or every 3 years. So Esog can take the lead for identifying the SRH receipt priority setting. The second, Esog can also be an institution for evidence synthesis and rapid response. Like we do have the journals, the society journals, but if you see the journals, majority of the publication is like either cross-sectional studies or case reports, but we need to move to more focus on policy briefs, consensus statements, rapid guideline briefs. That can be an input for the Minister of Health. And the third, the Esog can be a knowledge brokerage. Like we do have the data published in our society, but that data, even though questionable the quality of data generated by the cross-sectional study, but this data published in our society can be used for the policy. So we need to go to the ministerial heads. We don't have the data. This should be implemented into the program and the interventions, and it can also be a capacity building, like training our members in evidence appraisal and implementation science, and also in institution innovations. This is the most important. So it's okay, a team of experts from different academia, the private facility, so experts relation units that can continuously assess the available evidence to synthesize the evidence, prepare in a formalized policy brief voice that can be used for the policy. Thank you.
Thank you, Dr. Abel. I will summarize what he has said so far. He has highlighted evidence translation is mandated at Ministry of Health. He also mentioned that evidence to policy is embedded under HCTV, which is a very good opportunity to scale up, and university assignment to research, increased use of routine data system. He has also mentioned the key challenge in Ethiopia, for example, no institution to prioritize the research gaps, and funding is also a major issue. Type of research, late adoption of life-saving research, and translating evidence to policy, fragmentation of data. As a way forward, he also emphasized institutionalization as an important step, monitoring and strengthen routine data system, and shift in research from identification and assessment, and the need to improve the quality, and that Esog can play also proactive role, should play proactive role in many areas as an independent research lead, and policy doing policy briefs, consensus statement, knowledge brokerage to be used for policy and innovation. Thank you, Dr. Abel. Now we'll go to the other sub-team. The role of partners. We know finally resilience is rarely achieved by government alone, and the partnership amplify impact. How can NGO and professional societies be more actively leveraged as a strategic partner to strengthen SRH system resilience in Ethiopia? Maskara.
Thank you, Dr. Ahmed, and thank you, Esog, for having me here. As a midwife mentored by OBGYNs, I'm happy to be here and contribute my part. Before starting to share my thoughts, I would like to start by sharing some of the challenges our sector, especially the sexual and reproductive health sector, is facing over the past 2 to 4 years. It's good to mention the COVID-19 pandemic, the protest by USAID and other donors, coupled with the economic instability in Ethiopia, has put unprecedented strain on the health system. These are not the only challenges we are facing currently. We are also witnessing a global anti-choice and anti-rights movement, intensified by, especially at this time, by the reinstatement of the global gag rule, which is renamed by the Trump administration as protecting the life of for global assistance. This development has profound implication on sexual and reproductive health services, especially on family planning, safe abortion care, and gender-based violence, not only the response as well as the protection mechanism. I think, as rightly put by other panelists as well, this is the right moment which calls for collaboration, leveraging resource and shared learning and collective action among not only NGOs, professional associations, but calling upon private sector is also important to advance SRHR, because it's the right time to protect some of the sexual and reproductive health rights and ensure it's advanced as we go forward to ensure that individuals, families, communities, and nation as a whole have access to equitable and responsive sexual and reproductive health. So what are like the pathways forward? Like how can we leverage resources available, and what can we do differently? I think the first thing is at the start of this panel, the moderator was mentioning the health sector development and investment plan. Professional associations such as Esog should be engaged not only as implementers, but as a strategic partners. So this means like jointly planning initiatives and also leading some where some of the challenges are occurring at this time. And Esog can lead evidence-based policy dialogue to ensure that SRH remains a priority, not only a priority, but to ensure government takes it as a non-negotiable service during this time where we are witnessing some of the challenges I mentioned earlier. We can also leverage some of the experience from NGOs and donor networks, as we have seen some of the initiative taken by the Ministry Impact Intervention, I think, and we can also integrate some task shifting and task sharing, as Dr. Daniel mentioned earlier, and self-care approach, digital health are some of the initiatives we can take, we can strengthen to ensure that services remain available during this challenging times. The other point is professional associations, NGOs, and again public health, private health. Mention one of the examples by our self-service delivery organizations such as Mayor Stops International, which play a critical role in Ethiopia in expanding access to sexual and reproductive health and maternal health care. And I'm sure many of the models they have tested in their clinics and other interventions can be scaled to the national level. And professional associations like e-professionals, which is important to ensure that there is accountability among the professional environment as well. Not only the technical implementation, but the governance of the persistent challenges we are seeing in SRH, especially provider bias, community security, and inequitable access. So by strengthening the national and local institutions and grounding our actions in evidence and equity, I think we can preserve some of the progress we have made for the last 2 decades and ensure we build more resilient SRH system that is equitable and responsive to the community.
Ms. Karam, for a beautiful presentation. Let me ask 2 questions again to expand on this. How can Esog, Afog, and LIJIO better coordinate with government structure to avoid fragmentation? And how can these actors support continuity of essential services during funding shocks?
Thank you. I'll try to summarize my thoughts because it's broader questions. I think sexual and reproductive health requires not only good intention, but it needs not only good intention and isolated excellence, but it requires coordination, shared accountability, and collective action. Professional associations like Esog, NGOs like in gender health, they play critical role in ensuring and reinforcing some of the initiatives, not fragment government-led priorities, as mentioned in by previous speakers. The starting point is plan alignment. All partner initiatives should be aligned with our national commitments and our national strategies. I mentioned the health sector development and investment plan earlier. We also have a national reproductive health strategy, a commodity strategy, and other initiatives. So all partners should align some of their efforts with national commitments. And this means like moving beyond parallel thinking, project thinking, to addressing nationwide and some of the critical challenges as well. As rightly mentioned in the health sector development and investment plan, I think it mentioned that 1 plan, 1 budget, and 1 report. I think that's the area that all partners, professional associations should strengthen, because when our plans are aligned, investments will be more additive than fragmented and duplicative. The second point is strengthen coordination platforms. We do have strong technical working groups, task forces, and coalitions at the Ministry of Health, and coalitions led by different partners like Esog and in gender health as well. So it's important to strengthen these platforms and professional forums similar to this to ensure that the platforms are not only used for information sharing, but also to make some of the decision making, important decision making, and to ensure that we share some of the developments in our sectors as well. Today we have like different academicians, NGOs, and professional associations and frontline providers with us. So this platform, this forum can also be used to share some of the evidence-based standards of care and to ensure consistent implementation across regions as well. as I mentioned earlier, the critical gap we have in our sector is accountability and governance. So NGOs should invest in governance and accountability as well, and also supporting governments in some of the operational activities like disseminating policy documents, guidelines, and other initiatives at national level, because this is the critical issue that we are facing at national level. There is commitment, there is different guidelines, working guidelines, but when you go down to the regions, whereas and service delivery points, these policies are not put into practice. So this is a critical area for us to focus on. And professional associations like Esog, I'm sure we have seen like the pre-conference where different sessions were provided to ensure there is a continuous professional development, but these kinds of platforms we will also ensure to translate some of the guidelines and policy documents. And Esog can also take a leadership role by institutionalizing the clinical audits, mentorship, and bringing peer accountability among its members. Of course, NGOs should not bring like a standalone service delivery or other initiatives, but can support some of the government-led initiatives to maximize impact. Finally, coordination should be put into action. When government continues to introduce new initiatives, new curriculum, it's good for NGOs to be flexible, to shift some budgets, to retrain and adapt some of the support areas to the scale as well. And it means that aligning resource, retraining providers, and supporting monitoring systems. So to conclude this question, so maximizing impact is not about doing more, but it's about doing things together, like coming together as a professional as society, coming together as an NGO and private sector. It's about doing things more and better. It needs like strengthening available platforms like the technical working groups that we have, the professional conferences cross systems from national level to district level. We can build more resilient and sustainable system within the SRH system, though it's not, it can't be built overnight, but it's a work in progress and it can be attained as we go forward. I think you have also asked some of how can we ensure the continuity. I think I have mentioned most of my points earlier, like ensuring there is coordination in coming up together is important. The other is, I think Dr. Dammene mentioned it earlier, diversifying funding mechanism, because one of our challenge is there is a cut by major donors, including USAID and other European donors as well. So diversifying funding mechanism, especially domestic financing. I know the Ministry of Health is working on this, but we need to diversify domestic financing and encouraging private sector investments and other innovative financing approaches to ensure that these services are not services are insured and continue as we go forward. At the same time, professional associations like Esog, among other things, I think they should continue to advocate for us to have a budget line for SRH. This is one of the challenge. There is a budget for the health sector, but the SRH budget line is not similar across regions. So we need to advocate to have SRH reflected in the national budgets as well, so that we can continue some of the workforce development, the community, and other required essentials to SRH. And the other area we need to advocate is there is a 3-year compact agreement. I'm sure the one commitments are translated. Challenge should be integrated in our sectors as well. SRH by itself need to be integrated across sectors like education, legal aid, and other sectors as well if we want to be successful and resilient and ensure its continuity. And not only those services, but as well, we need to also address some of the gender norms and provider bias that's critical to ensure service access. So continuity is achieved through complementarity. And when governments provide strong leadership, as we are witnessing with Ethiopia case, and ownership and services remain accessible, like we mentioned earlier.
I will not repeat that, but a few points I would like to mention is, she has mentioned the major challenge that we are facing at this time, particularly the which is faced globally. She has mentioned there are opportunities for us, particularly the HCTP and Esog as a professional society can lead also evidence-based policy and task shifting, service delivery organizations also can. She mentioned a lot. One important issue: alignment is always most of the time important to avoid fragmentation. Alignment with national commitment, the need to have one plan, one budget, one monitoring system, and the opportunity to work under also coordinating mechanisms and platform, and the proactive role operation. Now we have covered the fourth sub-theme, maybe because the supply chain panelists has not joined us. We'll try to weave into the other sub-theme discussions. So I will now say something about supply chain. Maybe we'll involve also the audience to participate in this. And the supply chains of essential SRH commodities are the backbone of service delivery. HSTP and HSDIP emphasize a strong pharmaceutical system, local manufacturing and digital logistics as priorities without so let's keep this in mind as we move forward. Both HTP and HSDIP, the availability of essential commodities directly to service quality, equity and system resilience. So now I will go financing strategies also safeguard supply chains against aid cuts.
Thank you again for this opportunity. In the talking about supply chain, especially with regard to the critical SRH commodities that we want to protect, the most important thing is, looking at each stage of the supply chain process and explore, and again, as relevant to this plenary as well as the overall professional associations, what can professional associations do to address these bottlenecks in each process? As you know, there is the issue of within this bidding that can also be international. So then there would be distribution. Then storage and maintenance. And then comes utilization of the supply, the SRH commodities that have been brought through. And we would have issues of custom clearance and so on that can be considered as a bottleneck. In the distribution and utilization, there is a need for a lot of involvement of professionals and para-professionals at these services. When we talk of utilization of these services, as we know, for instance, the construction safety prevalence like more than 40%, but we still opportunities that we can address. So, what are the key stimulus as well as to enhance utilization of these services? One, the professional associations like Esog should be looking externally, not only internally, so that they can influence policy, they can advocate for, as well as sort of pressurize the government. When we talk of task shifting, activities should be done at grassroots level by para-professionals as compared to professionals. Professionals like physicians or obstetricians are someone who would operate autonomously anywhere with self-policing and so on. But para-professionals need continuous supervision and continuous support. So we need to make this realistic in terms of providing continuing education, and it can also be assisted through current digital mechanisms for this. And we also need to be to maintain the supply chain using using again digitally assist monitoring of inventory and so on and so on. So these are the issues, especially with regard to supply chain. In addition to securing and protecting the financial inputs, both from the government as well as from partners and from the private, public-private partnership, to make the supply chain process seamless, as I mentioned. Thank you.
Thank you, Professor Damman, for your detailed response. Now we'll move to audience engagement to allow participation from several colleagues. I kindly invite short, focused questions rather than comments. We'll take 2 or 3 questions. Not joining us. I would like the reflection from the audience. Since supply chain resilience is logistics or partner organizations on practical solutions you have seen, if there is any, say something about it. Anybody from the audience?
Okay. The president of OGS of Sudan. My question, first, before I ask my question, I just thank you very much for having this comprehensive presentation for the whole system. My question is that how we can make the community itself involved in the system, because you understand that they want to get the trust and they want to get engaged in the system. Secondly, simply they want to know to get the answer, where to go, and then also they want to know the answer, how are they going to get the care. Thank you very much.
Question. I have not heard because of noise.
Okay. I have to repeat again. I am Dr. Salahuddin Balol, the president of OGSS Sudan. Thank you very much for having all this comprehensive presentation for the system of our RH system. My question is that what is the role of the community itself to get engaged and they have to get trusted in the system, and they have to get engaged in it. They want an answer for their questions, where they can go on the whole system, and then how can they trust that when they go, they will get the care they are looking for. Thank you very much.
Okay. Thank you. Any insight about supply chain? Who can provide any practical solutions? Say something about that. Okay, maybe we'll go to responses from the panelists. The role of the communities in a system. Have you heard about the question? Yeah. And where the community should go in this. The role of the community in a strengthening resilience system. And where the community should go to get this.
Again, the community engagement is key in all health care processes, including ensuring the continuation and sustainability of SRH services. Perspectives where community can and how community can be engaged in this engaged in the planning and implementation of the process that we care about. The other thing is communities who are, as you know, beneficiary to the services they get. How can they enhance the utilization and the securing of these services? What mechanism do we have? One most important mechanism for ensuring this is the extension workers are expected to go house to house and get the communities get use services as well as in any of the services. The other thing is we can also utilize society institutions to get the communities engaged in ensuring utilization as well as making whatever process seamless within the community. The community associations would be instrumental in catalyzing as well as coordinating activities for the increasing demand and increasing the utilization in the utilization of SRH services, particularly contraceptive prevalence. This is what I can make as input.
Okay, anyone can add?
To complement on Dr. Damene's point, I think we can use two approaches. One is co-creation with beneficiaries, community members, during policy developments where they can share the gaps at grassroots level and issues that they feel should be integrated. I think most of NGOs use this approach during project proposal write-up. This should be integrated with the government sector as well. The second is community members serving as a board, as board members in healthcare service delivery point or at district level, to share their thoughts and ensure their voice is integrated across the healthcare delivery point. And we do have strong health community health workers, health extension workers in Ethiopia. I'm sure similar setup is available in Sudan, so community health workers can also lead dialogues and home visits where they can report to the next system to ensure the voice of the community is integrated government system. I think these are the 2 points.
Thank you. Maybe if there are additional questions and comments. Okay. There.
Sudanese Society of OBGYN. My question is, I didn't hear anything about the health. Now we are in the middle of this era of AI, and we can make use of it for sure to build up our resilience system. So how can we make use of it? Thank you.
Okay. Additional questions? Okay, the question is, I think, clear. The role of AI in resilience. Maybe it goes to you.
Okay. Thank you so much for raising this global initiative. I may not say in detail, I'm not an expert in the artificial intelligence, but we are now facing artificial intelligences integrating in different health, one form of AI assisted, identifying the research gap, developing protocol, developing study designs, developing implementation strategy, monitoring and evaluation. So in resilience healthcare systems, like developing the human resource, supply chain, infrastructure, AI in the healthcare system. Whether we love it or not, AI is going to be part of our life in the future. So every one of us need to adopt, implement the AI to have a resilient healthcare system. This is what I can say. I'm not an expert, but this is my thought. Thank you.
Okay, thank you. Again, I mean, in addition to what Dr. Abel has mentioned, as I earlier alluded, I mean, this AI is an emerging digital instrument to make some of the steps in the supply chain process seamless. Especially, we can use it in the storage, maintenance, and distribution of the commodities, because that would facilitate the creation of a proper inventory and proper monitoring of what has been distributed, what has been utilized, and what has been remaining. But this is one of the critical areas where AI can be used in the supply chain process of essential SRH commodities. Thank you.
Thank you, Professor Daman. I think time is running against us. So I'll now go directly to the closing statement. Distinguished colleagues and partners, as we conclude this discussion, several important themes have emerged. First, resilience in sexual and reproductive health system is not defined by any single intervention. It is built through integration, sustainable financing, reliable supply chain, a protected and motivated workforce, a strong evidence to policy pathway, and effective partnership must function together as one system. Second, we have heard clearly that as Ethiopia advances implementation of HSTP and HSDIP, the priority is not simply expanding services, but safeguarding essential maternal, newborn, and adolescent health services, ensuring continuity, equity, quality, even during period of transition or shock. Third, resilience requires intentional choices, ring-fencing life-saving services, strengthening accountability through data and digital system, investing in workforce retention and skills, and aligning partners around nationally driven priorities. Perhaps most importantly, today's discussion reminds us that resilience is not something we have achieved, we achieve once. It is something we continually build through collaboration, learning, and adaptive leadership. On behalf of the organizing team, I would like to thank our distinguished panelists for their insight and leadership, and the audience for your engagement. Let us continue working together towards a resilient SRH system that delivers for every woman, every newborn, and every community across Ethiopia. Thank you.
Okay. Thank you, our moderator, Dr. Abdul Hamid, and our panelists for this insightful discussion. I'm sure everyone has a better understanding of the challenges we face in everyday practice of the sexual and reproductive health system. And I particularly liked the part of the discussion on the need for research to practice and upscaling the next generation OBGYN practices. This is a call for all of us to step forward and fulfill our responsibilities in upscaling sexual and reproductive health service. So we wound up this plenary session with this. So it's now time for a short recess. We'll have a coffee break outside. You can take a 30-minute break, and we'll resume after this. But I will ask the Esog board members and the president-elect of the Afog and media personnel to stay here for a press conference, but the rest of you will have a coffee break. And this is also a reminder, there will be also a poster presentation during this time, so presenters and evaluators, please be at your position. Thank you. We'll rewind our session with this and be back after 30 minutes.